A patient presents with genu valgus deformity. I'm showing you an AP radiograph of the lower limbs. Describe the findings.
All right, let's take a look. The radiograph demonstrates a bowing deformity of the tibia and fibula. The metaphyses of the bones are significantly widened, producing a classic Erlenmeyer flask deformity. Furthermore, the expanded metaphyses are relatively lucent when compared to the central diaphysis, which is sclerotic and constricted. There are no specific features to indicate lead poisoning, osteopetrosis, or thalassemia. The diagnosis is Pyle's disease, also known as metaphyseal dysplasia. The differential diagnosis for an Erlenmeyer flask deformity includes craniometaphyseal dysplasia, Niemann-Pick disease, Gaucher's disease, osteopetrosis, lead poisoning, and thalassemia.
I am now showing you a radiograph of the humerus of the same patient. How do these findings compare? And how would you differentiate this condition from craniometaphyseal dysplasia and Gaucher's disease?
As seen in this radiograph of the humerus, there is a similar Erlenmeyer flask deformity with marked metaphyseal flaring, relative diaphyseal sclerosis, and bowing. Pyle's disease is a rare autosomal recessive disorder where patients are usually asymptomatic aside from cosmetic deformities like genu valgum. Craniometaphyseal dysplasia presents with essentially the same long bone features, but it is additionally characterized by sclerosis of the skull base, which leads to cranial nerve palsies. In contrast, Gaucher's disease is a lipid storage disorder that typically presents with generalized osteopenia, strikingly thin cortices, and often a vascular necrosis. Gaucher's disease would also present clinically with hepatosplenomegaly, which is absent in Pyle's disease.
The arrow on this image highlights the Erlenmeyer flask deformity we discussed. Let's delve deeper into the differential diagnosis. How would you differentiate osteopetrosis, lead poisoning, and thalassemia radiologically?
When evaluating an Erlenmeyer flask deformity, the presence of diffuse sclerosis and sclerotic vertebral end plates strongly points towards osteopetrosis. If dense metaphyseal bands, known as lead lines, are present, lead poisoning should be suspected. Finally, in thalassemia, chronic marrow expansion leads to a widened medullary space, a classic hair-on-end skull appearance, and generalized osteoporosis.
How would you manage this patient as a radiologist?
As a radiologist, I would document the extent of the skeletal dysplastic changes. Given the differential diagnosis, I would recommend a skull radiograph to confidently exclude craniometaphyseal dysplasia by checking for skull-base sclerosis. I would also suggest clinical correlation to ensure the patient does not have hepatosplenomegaly or cranial nerve palsies. Finally, I would refer the patient to an orthopedic surgeon for management of their genu valgus deformity and to a clinical geneticist for formal counseling regarding this autosomal recessive condition.